Great. Thank you for having us today and scheduling us as your entertainment after lunch. I'd like to start by sharing an experience I had yesterday on the flight here. There was a medical emergency on the plane, and I happened to be the only physician. For those doctors in the room, this is a perhaps recurring nightmare for some of us. It happened actually right in front of me, a young man who had a brief loss of consciousness, and I'm very thankful that he was probably dehydrated, and with proper assessment, which did not include the flight attendants, patting him on the cheeks, but checking for a pulse and making sure that he got what he needed. We did not have to divert the plane, and he was okay, and everything worked out. But it occurred to me in preparation for today that maybe one method of financing better care is to fund jaunts for doctors on commercial flights around the country, maybe some time off, and there'd be more physicians on planes to help for those having medical emergencies. So we're going to jump in and talk more about our system here.
Where's the clicker? Can we get to the next slide? Hello, everyone. Yesterday, our Chief Operating Officer asked if we could be disruptive innovators, and I think your idea is probably one of those disruptive innovators. I'm going to tweet it out. But before we begin our presentation, we wanted to give you an overview of Kaiser Permanente. Who are we? And I think this will help lend our conversation as to how we've been able to meet some of the milestones that we have. We're about 12 million strong members, with most of our members being in the California region. Actually, 1 in 8 Californian is a Kaiser Permanente member. If you do the math of 8.5 million members in a size of 30-something in California. We're primarily commercial plans. However, we have about 30% government-paid programs, bulk of it being Medicare, and it's about 10% of our membership, but about 30% of our business. And we're primarily Medicare Advantage. So that'll give you a taste of sort of how we operate. You'll see the slides. The other point I wanted to make is we own and operate a number of our hospitals as well as clinics. So it's really a one-stop shop for our members. So as you come into our facility, it's very likely you'll see the patient, go to the pharmacy, the lab, x-ray, whatever you need within 100 feet of each other. We've recognized leader in quality and service. We continue to be a 5-star program, receive accolades in the Pharmacy Quality Alliance, NCQA, et cetera. I can share with you that anytime we look at any metrics or programs, the next question is, who's the best and how can we get there? We put that as a benchmark and try to hold ourselves to the highest standard. We have about 200,000 employees, about 22,000 physicians that are employees of the medical group, and I'll show you that in a minute. And that's one of the reasons I think the secret sauce of our alliance. And we have, you can see some of the statistics there, but one of the other the value we bring, we have one of the largest electronic health records. We have records on individuals back into the 90s. Has anyone here a Kaiser baby? See, there's usually 1 or 2 in the room who were born at Kaiser Permanente. So imagine, and they're continuing to be members well into 20, 30 years. Next. So if you were to ask sort of our secret sauce to our success, I think this slide really depicts who we are and how our finances are aligned. We're not a revenue center. When we see patients, we don't think about the copays. We take care of patients and it's collective. So our revenue comes from either our group or individual contracts or some prospective payments, government payers. And our expenses, the way we're aligned, I think is really our secret sauce. So we have our health plan, and that's sort of our insurance agency that collects the premiums. And then there are agreements made with the medical group as well as hospital in terms of care delivery. The hospital and the foundation are nonprofit. The medical group is a for-profit agency and has its own board of directors and governance process as well. And again, to highlight, the physicians are employees of the medical group and have service agreements. Earlier, someone talked about having aligned incentives. We have aligned incentives on many of our quality as well as financial regulatory initiatives across those three entities. So I think that really helps us stay on the same page and drive and deliver for care delivery. And one last note around this is I want to mention we're a very strong labor management partnership as well. Next slide. We wouldn't be here today if it wasn't for the visionaries of Henry J. Kaiser and Sidney Garfield back in the 40s after that opportune encounter they had in the Mojave Desert and creating this institution of prepayment, the group practice, and the model we have. And just one trivia and food for thought. Henry J. Kaiser was on the short list for vice presidential candidate for FDR. So just something to think about. What would have happened if he was that vice presidential candidate? And how would we have brought Sidney J. Garfield into the mix? And would we be having this conversation today or a different conversation? So with that, I'm going to hand it to Dr. Wang to talk about our care delivery programs.
Great, thank you. So our approach for comprehensive financing of serious illness care begins with population health. So it's not just about end-of-life care. And we are, because we're capitated, we're accountable for our entire membership. So it behooves us to touch our patients at every opportunity. We capture them when they come in for an office visit. We can identify care gaps and address that. And if they leave and those needs aren't met, we can follow them with the appropriate resources to have those care gaps closed. This integrated system for evidence-based screening, disease detection, and optimal disease management is called Complete Care. We started this in 2004 to improve HEDIS measures, to activate our specialty clinics toward this effort, and to leverage team-based care. What we found is that with an average improvement in HEDIS at the 50th percentile of 5%, we were actually able to improve our own measurement an average of 13% across 51 HEDIS measures. So what it looks like, for instance, is you could have a patient come in for an eye appointment and they're overdue for a mammogram, and we can direct book that appointment that day. And because we're integrated, maybe they don't touch a physician-based office encounter, but they come into pharmacy for a refill, and we see that they need an A1C testing, and we can go ahead and get that done at that time. And that's the Complete Care program. You can see that it saves us millions of dollars as we provide improvement across these measures. One of the successful components of Complete Care is what we call the Online Personal Action Plan, or OPAP. This is an email-based outreach that links to a personalized action plan for every patient. And what it does, it will target patients' pre-office encounter to prepare them. It provides updated missing labs, screening studies, and patient decision aids to prepare them for a specific visit. And of course can follow them outside of any kind of direct encounter touch. So this is one way that we leverage advanced care planning services as well as optimal disease management if their A1C is poorly controlled, for instance, in diabetes. The OPAP tends to, for those members who use it, we have a higher rate of gap closure in this population. And you can see, for instance, in our goal to reduce colon cancer mortality, just in the last year, we had 13,000 FIT kits that were ordered through OPAP with a near 70% return rate. Another component of Complete Care is called SureNet. And this program is used to augment medication safety and disease detection using protocols that we built into the electronic medical record. So for instance, if we want to be sure that we detect GU cancers, we can look at all our urine samples for gross hematuria in the outpatient setting. So there might be other reasons for hematuria, but this is also a lab issue that could be overlooked by a primary care physician. And we were able, in this sampling, we looked at 2,200 urine samples with blood, and it led to almost 600 diagnostic interventions through cystoscopy, and we were able to pick up 17 cancers and 41 other abnormalities. This is another effort of SureNet, one of our first initiatives that we built into the SureNet program, looking at amiodarone and more closely monitoring. So this particular drug has drug-drug interactions and can affect thyroid and pulmonary function tests. And we weren't consistent about monitoring that. And through this program, we were able to reduce that variation, reduce adverse outcomes related to this medication, and save a ton of money. You'll notice I won't be that specific regarding cost savings. So the term Moonshot derives from the Apollo 11 space flight that sent the first man to the moon. And it typically refers to an endeavor that's high risk with an uncertain outcome. And we've chosen to set some Moonshot goals for ourselves as an organization. And this is one of them. It's the goal that we set is to reduce colon cancer mortality by 50% over 10 years. And as you can see, we're currently on track. It's each year is a composite of 3 years, so you're looking back a little bit. And in the initial stages, we've been focusing on screening through colonoscopy and FIT testing, and also appropriate follow-up of anemia, which is an area in medicine that could be missed. But we're also working on reducing variation in treatment for advanced colon cancers as well, because even a stage 4 has a 20% potential for cure within that population. In our system, the cost of colon cancer diagnosis is $30,000 per patient per year, so it does translate into cost savings as well as, of course, and most importantly, supporting the patient themselves. So let's go ahead and pivot to inpatient medicine for a minute. I know there was a lot of discussion this morning about days at home, care in the home, which is what so many of us are interested in. And so we've made this effort to really look at hospital days in part to enhance that ability to keep patients in the home where they want to be. And we have been able, over the past decade, to reduce our hospital utilization by about 30%, which does translate into, billions of dollars in cost savings for the entire enterprise for us, but also allows patients to receive higher quality care in the home setting. The care without delay model includes several basic elements of quality, both medical and non-medical. And some of the key factors include asking the question, do it today and why not now? And also removing barriers to timely treatment for many patients. So speaking of non-medical, we know that when we're thinking about the total health of patients, at least 80% of that is made up of non-medical sources. So we are always talking about the healthcare system and what we implement, but we're very interested as an organization to explore this area. So we did do an intervention where we looked at 3,000 individuals that were predicted to be in our highest 1% of utilization, and looked at their social needs. And the top most prevalent needs were caregiver support and financial and food insecurity in this group. And cost was one of the outcome measures. Did you want to speak to this?
This is one of my favorite slides. And because the story behind this is that when we looked at cost and utilization of those 3,000 members, this is a preliminary deck showing us that there's no impact. But again, it brings us back to one of Kaiser Permanente's tenets of following evidence-based medicine. This was a preliminary slide. We haven't yet looked at propensity risk scores to match the patients, and what I've heard is that there is an impact. We're seeing that there's potential impacts. So we will be publishing this study, and then as a consequence of that is developing our program much more robust to address social needs.
And next, we wanted to share our most important investment, because it's my program. And this is the life care planning system. This is really a systematic approach to advanced care planning based on respecting choices, which is now under CTAC. And what you can see here is that we use segmentation, which is a model developed in KP Hawaii, to stratify our patients by morbidity and mortality risk. So up at the top, you can see most of our members are in care groups 1 and 2, 76%. And then the target for this group and our efforts to normalize advanced care planning across the continuum include really this first steps component. So a lot of this is directed toward online life care planning and class-based discussions for patients and any family member or friend. And the focus is on the what-ifs for them, naming a healthcare agent, thinking about future events that could happen. 16% of our patients are burdened with chronic illness, and 8% have a more advanced or serious illness that could be life-threatening. And you can see that the steps we take to address folks in each stage vary. So in the middle stage, it's really about shared decision-making that tends to be disease-specific. So if I have heart failure, then it's what kind of treatments would be optimal for me. Am I a candidate for ICD or LVAD or transplant, or what medications might benefit me the most? And in this last section for patients with more advanced illness, it includes having pulse-type conversations or questions around the value of treatments at the very end of life. The implementation of this program has been around $500,000, and we've intentionally not used cost or utilization as an outcome measure. We wanted to keep this focus on quality, but published literature does suggest that when we align treatments with patient values, that there may be potential cost savings down the road. So this is what Kaiser Permanente is about. It's integration that allows us to be patient-centered. And I think for patients with serious illness, this is especially important because they're more likely to have those transitions. So if they need palliative medicine, for instance, we are not only in the hospital and in the clinic, but we can do virtual visits through video, we can do phone visits, we can go and do community-based palliative care, we have our own hospice agency, and we have palliative care in the skilled nursing facility contracts that we have as well. So it wouldn't be uncommon for us to have a single physician actually follow that patient across from site to site as they experience those transitions. And this is, I think, what really helps us to optimize the care for our patient population. Thank you.